Hello, my name is Leslie Hunter Johnson, and I am a board-certified adult gerontology primary care nurse practitioner, and my primary focus of specialty is in palliative care. Palliative care is a philosophy of care for individuals who have distressing symptoms of chronic disease states. I am a Doctor of Nursing Practice candidate at the University of South Alabama, and this is a review of my scholarly project. Even before I enrolled in the University of South Alabama, I had a passion for palliative care. This program has strengthened that desire to enhance quality of life for both the patients and families served under this process. In addition, I have provided an opportunity for other practitioners to obtain the knowledge and skill set necessary for this growing population, and this has been very rewarding. This project is the end result of my scholarly project. Thank you for the interest, and I hope you enjoy my program. My scholarly project is entitled How Patients' Perception of Care is Improved if Practitioners Have Education on Palliative Care. The design of the project is a quasi-experimental pre- and post-study quality improvement project. The project involved assessing the patient's baseline perception of care provided by the home-based palliative care team. Following the baseline assessment, the team members received education on palliative care training, and following the education, the patients were once again polled to determine if the perception has improved. The following is a presentation of the finding of this project. According to the Center to Advance palliative care is one of the fastest growing healthcare disciplines nationwide. Palliative care is a specialized type of care that helps individuals deal with serious illnesses. Palliative care providers are symptom management experts and may help with assisting in providing relief from the stress of these chronic disease states. The symptoms may include, and are not limited to, pain, depression, shortness of breath, fatigue, constipation, nausea, loss of appetite, difficulty sleeping, anxiety, or any other symptom identified by the individual. The goal is to provide quality of life for both the patients and the family as a unit. It is appropriate at any age and any stage of a serious illness. According to the Center to Advance Palliative Care, 77% of acute care hospitals have some form of palliative care services. The models vary from organization to organization and are basically three separate models: primary care, consultative, or collaborative care. Unfortunately, at discharge, there is lack of qualified providers that will be able to assist with continuation of care. To meet the growing needs of this population, many hospice programs have began providing palliative care services to these individuals. Unfortunately, it is important to understand that although hospice and palliative care share some philosophies, they are not the same. Transitioning a hospice provider where he or she is focused on the terminal illness and where the goal may be to deprescribe, to a philosophy of care for people who have serious illnesses that may be curable and not terminal, and escalation of care may be warranted, is often difficult. The needs assessment led me to this project where I developed and delivered a sustainable educational program where hospice providers can gain additional knowledge to fill the practice gap of palliative care. Aligning with the essentials of doctoral education for advanced practice nursing, this is where the emphasis came from. Although all 8 essentials are important, this project specifically addresses essential number 7. This is where the Doctor of Nursing Practice graduate is able to address the practice gap of individuals, aggregates, or population. The ongoing education based on adult learning theory will be able to fill this practice gap and deal with these individuals for the fastest growing healthcare discipline. The project purpose is to assess the patient's perception of care when providers have received palliative care education. The purpose is to improve the patient's perception of quality of life. Patients' perceptions are subjective and hopefully can be by the provider's care, to provide a sustainable educational platform that will allow providers to access learning modules at his or her convenience. Next, to propel the Elaine Wynn Palliative Care program closer to being able to seek certification through the Joint Commission in community-based palliative care. Here is the background and why I feel this project is both timely and relevant. Prior to the implementation, there were a limited number of resources for providers to obtain palliative care education. The gold standard is, and still remains, the LNEC training to obtain knowledge on end-of-life care. LNEC stands for End of Life Nursing Education Consortium, and that began as a grassroots effort from the City of Hope using a Robert Wood Johnson Foundation grant. This training has been translated into 8 languages and is available in 88 countries. The goal of LNEC is to improve the care for those at the end of life. It has specialty tracks that include core curriculum, critical care, geriatrics, pediatrics, Veterans Administration, and advanced practice nursing. Again, the focus is on end-of-life care, but only portions of the program deal with palliative care. Other venues to gain palliative care knowledge is through on-the-job training. This is tenuous at best because, as this program has indicated, there are few qualified providers. Lastly, most of the providers that do have a background on palliative care have obtained this knowledge through academic centers. I added to my previous knowledge of palliative care after I attended the University of South Alabama subspecialty track on palliative care. The lack of adequate training and lack of options led to this project development and access to provide increased knowledge and access to palliative care for the community providers. After the project, there will be an expanded base for providers to gain additional knowledge. To add to this program, I have selected modules out of the Comfort series. The Comfort series stemmed out of another City of Hope grassroots effort, and it is focused primarily on individuals who have an oncological concern, but is appropriate for palliative care as well. Comfort is an acronym that stands for the 7 basic skills of healthcare communication. C for communication, O for orientation and options, M for mindful communication, F for family caregivers, O for opening, R for relating, and T for team. The learning modules were translated into a format that will allow employees to electively select these modules from an online learning form. Elaine Wynn Palliative Care and Nathan Adelson Hospice use the platform known as Cornerstone. The modules will be available from the catalog and can be electively selected at any time. This will allow tracking for completion and is available for every employee at the organizations. Additionally, advanced care training was made available to the providers on physician order for life treatment, also known as PULSed. The Nevada PULSed Coalition has an online training module, and this website and link were also uploaded to the Cornerstone platform. In addition to the education, the providers were also given training on specific selected tools that will now be part of the patient's record. There were 4 tools that were selected. The first one is Age Aid tool. This is a screening tool for both substance abuse and alcohol. The second is the FICA spirituality tool. The third is the patient health questionnaire, made available both in English and in Spanish. And fourth is the Columbia Suicide Severity Rating Scales. These standardized forms were developed and delivered to the providers and are now part of the standardized. The components of this education and standardization was designed specifically to meet the joint certification for palliative care And this is a goal of Nathan Adelson and the Elaine Wynn Palliative Care. This certification will further propel this organization to a center of excellence. After approval was obtained from the Institutional Review Board from the University of South Alabama, the project began, and the data collection was from a 30-day period, beginning in late January 2017, ending in late February 2017. The design, as previously stated, was a quasi-experimental pre- and post-intervention assessment. Patients included in this study were those enrolled in the home care program of the Elaine Wynn Palliative Care Program, division of Nathan Adelson Hospice. There were 24 participants in all. Participation of the patients were voluntary, but there was no informed consent required. As previously stated, the 24 patients participated. It was a study of convenience because they were all enrolled in the Elaine Wynn Palliative Care Program. As the principal investigator, I selected tools that will help me assess the patient's perception of healthcare over time. I selected the Centers for Disease Control and Prevention Health-Related Quality of Life Version 4 survey. The survey encompassed 14 questions, and it assesses an individual or group's perception of physical and mental health over time. The other tool that was included was the Healthcare Relationship Trust Scale Revised. This is a 13-question survey that was used to evaluate the trust in the provider. Each patient was assigned a patient identifier, and the survey results were collected both pre- and post-intervention. The surveys were either in person or via telephonic response. After the baseline was obtained, the educational process was delivered to the providers, including the standardization of the patient chart tools. Following the education, I validated that the providers had indeed completed the education and the necessary requirements, and then I recontacted and surveyed the participants. I also tabulated how many encounters each patient had during that 30-day period. In addition to the previously two described surveys, the patients were polled to assess if advanced care planning documents have been completed. At the follow-up survey, the question was again polled to assess if any had additionally completed those documents. The data analysis was completed through a statistical program, and the results are as follows. Let's move on to the actual results. The patient's responses to the questionnaires were sent to a statistician for analysis, and the results are presented in the table before you and are as follows. Initially, data screening began with evaluation of both pre-test and post-test differences in the scoring, looking for outliers, and none were found. It was determined that the Healthcare Relationship Quality of Life Version 4 survey would best be evaluated using non-parametric sign testing, and this would assess for the pre-test, post-test changes. Overall, patients reported significantly fewer unhealthy days post-intervention, with 54.5%. 9.1% of the patients showed no change, and 36.4% showed deterioration. On the questions that evaluated depression, 50% reported less depression. 1 showed no deterioration, and 10% showed no change. Moving on now to the Healthcare Relationship Trust Scale Revised. This was evaluated using paired sample t-testing. The results showed that 83.3% of patients showed an increased trust in the healthcare provider following the intervention, while 16.7% showed no improvement. The final metric that was tracked was the advanced care plan completion rates. Prior to the intervention, 3 out of the 24 patients reported completing these documents. Following the intervention, an additional 3 patients completed these documents for an overall increase of 14.2%. In summary of the results, using the Healthcare-Related Quality of Life Version 4 questionnaire, patients reported fewer unhealthy physical and mental health days, fewer days with pain, and less days of depression post-intervention. On the healthcare-related trust scale revised, 83% of patients showed an overall improvement in trust in the providers post-intervention. And finally, advanced care completion rates. There was an overall increase of 14.2% of advanced care completion rate documents post-intervention. The tool before you is known as the Fast Pass for Palliative Care. This may be one of the most satisfying portions of my project. The Fast Pass is an original work created by myself, and it is designed specifically for the Elaine Wynn Palliative Care program. The goal is to facilitate consults to the palliative care team if and when a patient needs to seek acute care services. It has been very successful and has now been adopted into the hospice program of the Elaine Wynn Palliative Care parent company, Nathan Adelson Hospice. It has also been submitted to the Center to Advance Palliative Care for consideration of best practice. Let's turn now to the section of limitations and biases. The limitations include a small sample size. There were only 24 patients enrolled in the Quality Improvement Project. Those 24 patients are representative of the entire enrollment of the Elaine Wynn Palliative Care program. The limited data collection window of 30 days may have provided many limitations. A longer collection window may have resulted in different results. Next, the Healthcare Relationship Trust Scale Revise has only been tested in large samples of greater than 300 participants. Under the bias section, there may have been a participation bias. I did select patients using a non-randomized sample of convenience. 100% of the participants had some form of chronic disease states. Next, there is social desirability bias that needs to be addressed. There is a desire to please the surveyor, and sometimes people give the results that they think the survey is looking for and not the results that are true. In addition, avoidance of negative aspects of their life may have influenced the outcome of those questionnaires. The conclusion of the project is that the patients did indeed have an increased perception of improved care when their providers had palliative care education. The human component might be the most influential aspect of the project. The overall relationship trust was improved following the intervention, and the standardization of the tools provided enhanced and increased mindful communication. So yes, the patients had improved perceptions of care, but it's difficult to determine whether it was the human component or the intervention itself. Chronic disease states affect not only the patient but the family and caregivers as well. Consideration of involving a study or project where both patients and families participate may be warranted. Qualitative research is time-consuming, labor-intensive, and financially taxing, so funding in the form of grant writing may be warranted. And next, a randomized control trial with the use of a control group without chronic disease state compared next to those who do have chronic disease states may actually give a better picture of how palliative care can improve the overall health of an individual. Here are the key references used to create this slideshow. I thank you in your interest in my scholarly DNP project, and my goal is this will help propel palliative care to the forefront of healthcare.